I just want to express my deep appreciation for the opportunity to be here with you all today. It's really a privilege. This has been an amazing conference so far. And also want to encourage you to ask questions. This will be a presentation, but if you have any comments along the way, please feel free. I have no disclosures. And what I hope to achieve in this next little while is to share with you some of the research that we've done in the care of children with advanced cancer. And it's based on a framework of family suffering, and I want to share that with you. Then I want to look at primary palliative care interventions and how they may help to improve the well-being of children with advanced cancer and their families, and then think about subspecialty palliative care, and I'll review both of those definitions and its impact on family well-being. So to begin, as everybody is very familiar with the WHO definition of palliative care, just to sort of have us all be on the same playing field, palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness, and through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So when we think of palliative care, and of course there's many different names that are used, children's palliative care, pediatric palliative care. In any case, we think of it as an approach to care, and some of, I'm sure, the work that you all do is trying to change the paradigm from thinking of palliative care as a phase of care to palliative care as an approach to care. It's, as we just described, this process of blending care that's directed at the underlying illness and at the same time all those other important domains that I mentioned. And there's a continuous reevaluation based primarily on goals of care. I think of end-of-life care as a phase of care. So as you can see here, let's see if this, end-of-life care. When I think of end-of-life care, it's the period of time where we're nearly certain that a child will die from their underlying illness. That could be a period of time that's just moments, as in the time when a loving decision is made to discontinue a ventilator, and that child doesn't survive for very long. Or it can be days, weeks, or months, say, for example, in a child with advanced neuroblastoma, who we know with near certainty, if not complete certainty, that child is going to die soon. We can't say exactly when, but that the cause of death will be related to the underlying illness. And that's an end-of-life care period. And then, of course, there's bereavement care, and we know well from the literature and our clinical experiences that what we do before the child's death impacts greatly on the outcomes of the entire family. And what parents have told us is that if we embrace this approach of a blended approach to care, then we can maintain all kinds of hopes, which is hope for cure, when cure is possible, life extension, and even a miracle down to the last breath. And at the same time, hope for comfort and meaning, not an either-or approach. So just to be clear, and this is something that I think is more and more important to distinguish, is what's the difference between primary versus subspecialty palliative care. So primary palliative care is provided all the time by teams of clinicians who take care of seriously ill children, like an oncology team that consists of a doctor and a nurse and a social worker on the front lines. And we, of course, need to ensure that the skill set of that primary team is well developed with regard to palliative care concepts. And so it's the team that provides interdisciplinary support and integrates a palliative care approach. And then subspecialty palliative care is provided by clinicians that have expertise focused particularly on palliative care. And in the U.S., we have a subspecialty of medicine that's defined as hospice and palliative medicine, and you need to do an extra year of training as a physician and take a certification exam to be considered a formal specialist in this field. And the idea behind subspecialty care is that you provide care, consultative care primarily, in more complex cases. And you're also responsible as a subspecialty to enhance the education and move the field forward through training, innovation, research, and advocacy. So those of us who are subspecialists in the field see this as our professional mandate as it comes to palliative care. All right, so taking a step towards the focus of this talk, this is Dr. Eric Cassell, and he has written widely. He's an internist now in his 90s or late 80s. He's written beautifully on the experience of living with serious illness, and one of his books, The Nature of Suffering, has this definition of suffering. Eric says, Dr. Cassell says, suffering is a specific state of distress that occurs when the intactness or the integrity of the person is threatened or disrupted. It lasts until the threat is gone or integrity is restored. The meanings and the fear are personal and individual, so that even if two patients have the same symptoms, their suffering would be different. This, to me, feels like it captures the essence of what we're trying to ease. And we have used this definition as a means to kind of develop a framework for our research program. So we think about, in pediatrics, of course, not just the child, but family suffering. And when a child is diagnosed with a serious illness, it affects the integrity of that entire family, which includes the parents, the siblings, and the patient. And when we think about the threats that impact on this family's well-being, we think of the threats that are visible, those that are more obvious, like the illness itself, and perhaps some of the physical symptoms that we can measure a little bit more distinctly. And then, of course, there's a whole host of invisible threats. That is disruption from just what is typical or normal life. The often invisible emotional and social problems, and the socio-demographic factors that impact on this family. And all that together, of course, results in suffering. And it is our responsibility to think about targeted interventions like a specific medication for a symptom and global interventions. And one of the global interventions that I think of as a critically important procedure in palliative care is communication, and we're going to talk more about communication this afternoon. But that's sort of a global intervention, or a palliative care consult is a global intervention, all with the goal of restoring family integrity. It will never be the same. It will be new. It will be different. But the hope is that families emerge whole again through the course of this experience. So using this framework, we've kind of defined some aspects of suffering which we know clinically, but then have shown empirically through research, and start to think about interventions that we can study. So I'm just going to share some of the research that we've done, and this is research that identifies or names the social suffering experienced by families of children with cancer. This study was done by one of my mentees, Dr. Kira Bona, whose whole program of research is trying to understand the sort of impact of poverty on child outcomes and family outcomes in serious illness. And here she's taken the construct of household material hardship. So not having enough food to put on the table, energy for heating the house, or even having a house itself, and what happens from the time of diagnosis to 6 months into treatment. And what she showed, sadly, was that while 20% of families in the U.S. come into treatment with some sort of household material hardship, after 6 months of treatment, 30% of families have household material hardship. So the illness experience itself is associated with worsening household material hardship. So again, as we think towards interventions, we need to think about the team aspect of care. So we have resource specialists and social workers and psychologists who can help within the context of this risk for family suffering. And this study was done by Abby Rosenberg, and I was talking about Abby last night, who's a pediatric oncologist whose primary area of research is resilience. However, she has done some analyses using our data as well. And again, it's just to highlight some of the family psychological distress that they experience, and this is parent experience in particular, using a measure called the Kessler-6. What Abby showed in this analysis is that there are factors that are associated with higher or lower parent distress. So if you look at the bottom line, what is no surprise based on the earlier slide, a great deal of financial hardship due to the child's illness results in higher parent distress. And overall child suffering results in higher parent distress. And then there's this issue of whether or not the prognostic understanding of the parent is aligned with realistic goals. That results in lower distress. So if we can, through our interventions, help families have goals that are aligned with their prognostic understanding, we can actually decrease the distress that these families are experiencing. And again, we do this through our team approach to care. And then Abby's done another analysis of our data, looking at, we heard a little bit about the sibling, we heard a lot about the sibling experience yesterday, and this is just one example of the suffering that siblings experience. This study shows that the year after the death of a child is where these siblings are most vulnerable. And you can see there's a peak with regard to anxiety and depression in these bereaved siblings, and they have higher risk behavior, that is, using illicit drugs and drinking alcohol regularly to daily in that 1 year following the death. So we know from a general pediatrics perspective, as we embrace the family beyond the death of the child, that this is a particularly vulnerable period for siblings. This study was done by colleagues at Children's Hospital of Philadelphia under the leadership of Chris Feutner, and this is about spiritual suffering. These are all the domains that families identified when thinking about the religious, spiritual, or life philosophy experience with a child receiving pediatric palliative care. It's hard to read, but most of these domains are positive. However, we have to realize that for some families there are spiritual crises in the context of these illnesses, so that the role of our chaplains become extremely important, and community spiritual leaders. So this first set of data is just to underscore the need for easing suffering, enhancing well-being through the work of an interdisciplinary team. And of course, this kind of encircling the family of physicians and nurses and chaplains, psychosocial clinicians, pharmacists, community providers, does not include the universe of all the people that take care of these families, child life specialists, for example, school teachers, and we also heard yesterday how a single child can be touched by numerous providers in their care, all with the goal of easing suffering. All right, so the second question is then, does primary pediatric palliative care integration improve family well-being? Now, some of you may have seen this slide in Rome, but what's the most common response you get when you ask a child, say your own children, how was school today? Fine. Okay. In English, no matter where you are in the world, it's like the universal answer, right? Fine. Similarly, when you ask a child in your office, in your clinic, how are you feeling today? It's similarly fine, right? We don't necessarily think very systematically about how to elicit what's really going on with the child. And of course, we know that behind the fine are all kinds of deep feelings. And we have to figure out a way in which to elucidate those feelings. So with my partner in crime, Veronica Dussel, who's a pediatric palliative care physician, with whom I partner in almost all my research, we developed the PediQUEST study. And PediQUEST is Pediatric Quality of Life and Evaluation of Symptoms Technology. It's at the time, simply a computer-based data collection system that collects child or parent-reported symptoms and quality of life. And the system can summarize the data, questions that are answered by children of all developmental ages above 5, and then produce a report that summarizes how they're feeling. And so we developed this technology and had the hypothesis that if we increase awareness of providers and parents about child's symptoms and quality of life, we will decrease the child's experience of suffering. So the idea here was to amplify the child's voice and primarily collect these data from children themselves. We did enroll children 2 years of age and above who had cancer that had advanced beyond initial treatment, so not necessarily at end of life, but still earlier on in the illness trajectory. For the 2 to 4-year-olds, the parents did answer the questions. However, for 5 and above, 5 to 12, the children answered many questions. In the younger age group, they were read to, and in the older age group, they did it alone on the computer. And of course, all the adolescents answered these questions themselves. And it was a randomized study where the control group simply used the system to answer questions, and we used the Memorial Symptom Assessment Scale and the PediQUEST, symptoms and quality of life measures, to track over time. And this was administered at most once a week, at least once a month, for the period of time that those children were enrolled. In the intervention group, the system produced a report that summarized the scores of these kids over time. So the right-hand side shows the most recent scores, whereas you can compare how they were doing, for example, here with regard to quality of life and the different domains of quality of life over time. And we gave those reports, they were paper copies at the time, to parents, to children, and to their interdisciplinary clinical team, all to see whether or not, if they actually saw in greater detail how the child was feeling, whether or not that would lead to improved quality of life. Now, the study was helpful, even if it didn't change outcomes, it may or may not have, because from a parent perspective, they said these reports in 100% of the cases helped me to better understand how my child was feeling. The fact that they didn't know and knew was extremely meaningful to these parents. The kids themselves found the reports easy to understand and that it helped them talk to the doctors. The parents didn't worry about confidentiality, so generally speaking, the families appreciated these reports. From a provider perspective, there was also an appreciation, especially that the reports, remember we talked about invisible symptoms. The reports provided new information about psychosocial issues 61% of the time, so sort of bringing to light less visible symptoms. They actually led to action like consulting a specialist. They were useful 50% of the time in speaking with patients. They didn't increase the consult time. They didn't open up Pandora's box. And in general, they were somewhat to very helpful a majority of the time. So the question is, did this make a difference in terms of the actual outcome of child quality of life? And the results were mixed. In general, if you can look at the middle bars, those are the quality of life scores. And in the intervention group, quality of life was significantly higher than in the children who were in the control group. Or at least it moved in the direction that we had hoped, except it was only significantly higher in a subset of kids, mostly the older children and the children who were surviving, as opposed to those kids who ended up reaching end of life during the study. So there was something helpful amongst the healthier cohort of children. This overall sickness score also went down, and symptom distress scores went down, but none of those reached significance. And so in some ways it was, to a certain extent, it was helpful. It showed signal in the right direction, but wasn't a home run. Importantly, we asked families, just to name that, it's not easy to do these studies in children who are more seriously ill, and we asked them why they enrolled in a study like the PediQUEST study. And the most common reason in this word cloud was to help other children. So this altruistic, the desire to contribute even as your own child is very sick. That it was important that my child, because every child had to assent to the study, my child wanted to participate. And then you can see this other column in the vertical. We did give gift cards, so that was an incentive as well. So our conclusion for this study was that the PediQUEST study, based on what we learned, feedback of child's symptoms and quality of life alone has some effect on child suffering, but can be strengthened. And so it begs the question, why is it not strong enough? Why is feedback alone insufficient to significantly improve symptom distress and quality of life outcomes? And you may all have your theories, and we did some qualitative work in order to better understand this. Following the study, we decided we needed to know more in depth. What happens when a child reports a distressing symptom? How does the family react? How does the child react? How does the clinical team react? And so we did this 360 evaluation of children and their families. And what we found was this normalization of symptoms. So the fact that everybody expects the child to have symptoms and distress from those symptoms and accepts it as opposed to sort of wanting to ease it. And part of that is prioritization. When so much is going on in the care of a child with advanced cancer, you just sort of, it's par for the course in your mind, in your parent's mind, and in the provider's mind, that these childs will have distressing symptoms. and it's related to attitudes, expectation, knowledge and skills, and practical considerations when you're thinking about the chemotherapy and needing to sort of get through the day-to-day of administering that chemotherapy. It's hard to focus on symptoms. That was an outcome of this study. I'm going to move now to the question, does subspecialty palliative care improve family outcomes? And I'm sure that you are all familiar with the Jennifer Temmel study that was published in New England Journal of Medicine now some years ago, in 2010, if I recall correctly, where she looked at patients, adults with advanced cancer, advanced lung cancer, so metastatic lung cancer, and randomized those adults to receive palliative care consultation or not. So this is subspecialty palliative care consultation. And in that study, not only did she show that depression went down and quality of life went up, however, what was also very striking was that length of life or survival improved in the cohort of patients who received palliative care consultation. So that there was something about palliative care that led to longer life. Now, I can understand that. I'm sure you guys can too, right? Why is that? It's because sometimes less intervention is more. There's less effect on the body, and also a focus on well-being and strengthening and resilience also can increase survival. So to me, it makes perfect sense. And I'll just point out that Marie Bakaitis also, these studies, these findings have been replicated in terms of both improved quality of life and increased survival based on subspecialty palliative care integration. We don't yet have studies in pediatrics. We have some data that suggests similarly changes in outcomes. So this was a study we had done just looking at the perspective of bereaved parents before we had a palliative care service and after our palliative care service. And we found that parents were less likely to report high suffering from very common symptoms experienced in their child at end of life in the era of having a palliative care service. Also, in the era of having a palliative care service, the number of deaths in the ICU dropped off dramatically. And we also found that the timing of resuscitation status orders were earlier, and the involvement of hospice programs occurred earlier as well. So in this before-after study, there was also a suggestion of improved outcomes in children with cancer. And then there are many, many studies now that are showing, looking retrospectively, comparing children who receive palliative care to not receiving palliative care, or children who received earlier palliative care to late palliative care, and how that's making a difference in their experience. So this study done by Stefan Friedrichsdorf and colleagues showed that children who received palliative care were more likely to have fun and to have experienced events that added meaning to life. This study by Alicia Kassam suggested that families who receive pediatric palliative care and oncology reported improved communication. We have a study that was recently published showing that children receiving palliative care had shorter hospitalizations, fewer emergency room department visits. Children undergoing stem cell transplant, palliative care associated with less intervention-focused care. And in the St. Jude population, palliative care was associated with less intensive treatment at end of life in an AYA patient population. So growing kind of cohort data showing some improved outcomes in children receiving palliative care. And I'll just end by sharing with you a study that I hope to report on in about 5 years from now. But we received funding now to actually study in a randomized control fashion whether or not early pediatric palliative care consultation in children with advanced cancer have better quality of life outcomes. So the study is called PediQUEST Response, which is Respond to Pediatric Oncology Symptom Experience. And we're still using the PediQUEST system, which is now web-based, and there's an app for it. And that web-based system or app sends the reports now by email, so everything is paperless, that is. And our hypothesis is, compared to this just feedback alone, if you combine feedback now with a responder team, a team that's not focused on treating the underlying illness, but focused on that symptom distress, the palliative care team, if you combine feedback and early intensive follow-up by a palliative care response team, this together will more effectively reduce child symptom distress and improve child and family quality of life. And the reason why we think this is, if you think back to that normalization data, the goal of this study is to activate families to think about the fact that my child's quality of life matters, to sort of change from a more passive approach to symptom management and quality of life to a more active approach. And we think that a more intensive team to follow up on recommendations, both pharmacological and non-pharmacological recommendations, will actually move the needle finally in improving child symptom distress. But we don't have the answers yet. We're just starting enrollment in this study in 4 centers starting in January. I'll close by just thanking the Pediatric Palliative Care Research Team that I've had the privilege to work with over the years, and would be delighted to answer any questions. Thank you.